That's okay
Of
with
course.
you? Okay.
The more you
Okay,
get it
so
out,
it's a
the
little,
happier I am.
okay. So it is, so the next one we're admitting is Dr. Spear. He's our patriarch. He's our oldest member still with us. So he was one of the originals also. So, and he's, I think, one of the two left. There was only two rheumatologists in our group, even though we're the, rheumatic diseases subspecialty. So Dr. Teitelbaum, you really need no introduction, but if you want to just, let folks give you a 30-second spiel, and then the floor is yours. I will get out of your way.
So what I'll do is let me just go past the first couple slides and I'll give the intro. Again, in terms of disclosures, I make the Shine Ribose and Smart Energy System. I have some association with recovery factors, but pretty much I don't take money from any of the drug or supplement companies. So all the other stuff, I don't get a penny. So, people ask, what's a nice Jewish doctor like you doing in a field like fibromyalgia and natural medicine? And got into it the old-fashioned way. Came down with a nasty viral illness while I was in medical school. It knocked me out of medical school and left me homeless for a good part of the year. And it's funny. It's as if the universe put a holistic homeless medical school sign on my park bench. Naturopaths came by, herbalists came by, energy medicine people came by, and here I am, this med student. I've never heard of any of this stuff. But all of them taught me bits and pieces of what I needed to do to recover, be able to go back to medical school. And I spent the last 45 years researching. At this point, we've done 8 studies on effective treatment. We're submitting the last 2 are in the process of being submitted for publication. Written about 10 books, treated thousands of people, and developed what we call the SHINE protocol, which we'll talk about today, which has been shown in a randomized double-blind placebo-controlled study to help 91% of people with CFS and fibromyalgia improve, with an average 90% increase in quality of life. So we're going to teach you, if people come in complaining fatigue, CFS or fibromyalgia, to tell one from the other, or those with post-COVID persistent symptoms. We're going to go over today how to address these effectively. So let's look at some of the numbers. 31% of American adults have severe fatigue. Now, again, that doesn't count everybody who has fatigue. It's probably the majority of Americans have fatigue, and most people certainly want more energy. The principles we'll talk about today will address this as well. If you look at the human energy crisis, the tip of that iceberg, we're looking at about 2 to 4% or even higher who have chronic fatigue syndrome and fibromyalgia, which is like the worst case scenario for the human energy crisis. Post-COVID chronic fatigue, which is now getting much more attention. It's funny, the NIH budget last year was $12 million for fibromyalgia. I think they probably spent more on hangnails or stuff. I mean, it's like the Cinderella stepchild in terms of the attention it gets. That's gone up 100-fold, which will be 1.15 billion for the next 4 years. That's one of the thank you COVID things in terms of the bright side of it. But post-COVID fatigue, which is basically post-viral chronic fatigue syndrome and fibromyalgia, there are dozens of infections that can trigger CFS and fibro. COVID is simply one more of those. So we'll talk about how to address post-COVID in general with the CFS and fibro. And then at the end, we'll focus on the specific issues that are specific to COVID and how to address those. The focus today is not meant to dazzle you with thousands of studies and the numbers. It's meant to distill all of that into an easy to use clinical approach. So if you would like more on the science, ask me during the questions and stuff. But we're going to keep this really focused on what you can do now to get people better. So looking at the numbers, as I said, for CFS and fibro, about 2 to 4% of the population have overt CFS and fibromyalgia, and it's considered double that have an intermediate form. Post-infectious CFS and fibro are common after many infections. You'll see that in places and people who had SARS, the severe acute respiratory distress syndrome, 40% of those are severe cases. basically had chronic fatigue after, with 27% meeting the diagnostic criteria for chronic fatigue syndrome. If you take a look at people who had Epstein-Barr or Coxiella or Ross fever, again, you'll see 11% of these develop post-viral chronic fatigue syndrome. In a study by Leonard Jason, and people, college students who got mono while in college, 23% of them came down with chronic fatigue syndrome from the mono. And we can read all these things, but basically what the study shows is that numerous different infections will trigger CFS and fibromyalgia. And as I said, COVID is just one more, but it's one that's getting attention because all things COVID are big business and good for media profits. Sorry if I'm a bit of a, I don't want to say skeptic, but I find I take most of what is being fed to us with a grain of salt. So if you take a look at the symptoms of CFS and fibromyalgia and the symptoms of post-COVID, you'll see that the overlap is quite remarkable. So in those people who had COVID, 81% had fatigue afterwards. And those who have persistent post-COVID symptoms, these are the ones that months later. So 81% of those with persistent symptoms had fatigue, 74% had widespread body pain, headaches in 72%, 69% for brain fog, gut symptoms 67%, insomnia, which is a hallmark of fibromyalgia, 66%, and then the orthostatic dizziness, 61%. So we're seeing that, again, these symptoms are pretty much what you're going to, post-COVID, are pretty much what you're going to see in CFS and fibromyalgia. And Dr. Fauci has noted that post-COVID syndrome is basically highly suggestive of post-viral chronic fatigue syndrome and ME. So the question is, number one, if somebody comes into you and they say, I'm exhausted, I have severe fatigue, the number one question to ask them to distinguish, is this a day-to-day fatigue or other causes of fatigue, or do they have CFS and fibromyalgia, is, can you get a good night's sleep? Think about it. Most of us have been working really hard. We're exhausted. You give us a weekend where we can sleep, and we're out cold for the weekend. We sleep all day and all night. But in CFS and fibromyalgia, the hypothalamic sleep center is not working. Also, the sympathetic nervous system is not working. So what you're going to see is that you get that paradox of can't sleep even though you're exhausted. So number one question, somebody comes in with fatigue, can you get a good night's sleep? If they say, God, no, then it basically presumes CFS or fibromyalgia until proven otherwise, even if they have other conditions. For example, they may have lupus. You say, oh, it's lupus. No, it's a secondary fibromyalgia from the lupus. So even if they have other conditions, that paradox of can't sleep despite exhausted, that will sort it out for you very, very quickly. There are other causes besides the post-viral chronic fatigue syndrome that can cause post-COVID symptoms. You can see PTSD, which is very common, especially if they've been hospitalized. You'll see specific organ damage. You'll have a significant percent of people will have a myocarditis. You'll see pulmonary disease from the shock lung and interstitial lung disease. You'll see the CNS and brain fog. You'll see inflammation in the brain, which is likely mostly microglial activation, although you can certainly see strokes and other issues that are going on. So we'll talk about how to address each of those non-CFS parts of post-viral CFS, post-COVID symptoms as well. So number one, why are we seeing this epidemic of fatigue that's going on and worldwide? Well, what we are seeing is a perfect storm for the human energy crisis. We have 50% of our diet now comes from empty calories. Now think about it, 18% of our calories are sugar, 140 pounds of sugar per person per year added to our diet and food processing. Another 18% of calories from white flour. And when you look at it, over half of the vitamins and minerals in our diet have been removed. What we have left are calories. This is why we are seeing people being obese and malnourished together for the first time in human history. Meanwhile, if you look at sleep, sleep is where we recharge our batteries. The average night's sleep in the United States before light bulbs were invented was 9 hours a night. Now it's 6 3/4. So we have a 30% pay cut in terms of the amount of sleep that we're getting. We're seeing widespread hormonal deficiencies coming from aging, chemicals in the environment, hypothalamic dysfunction associated with stress, and a host of other causes. We're seeing infections that are coming to surface that with antibiotics have been controlled, and now we're seeing Candida, new viruses like COVID, this increased stress and speed of modern life. And there's many, many different things that are triggering the human energy crisis. So we talked about low energy. So what does that do? Okay, so you're just gonna be tired, right? It goes way beyond that. When you don't have enough energy, number one, you get muscle pain. A very important concept, especially as osteopaths, is that when you don't have enough energy, the muscles don't go loose and limp as you would think intuitively. They get shortened. It takes more energy for the muscle to relax than to contract. That's why during low energy, you have a heavy workout and your muscles have low energy. You don't come home and say, honey, muscles are all loose and limp. You come home and say they're all tight. So low energy causes the muscles to get locked in a shortened position. And that is arguably the most common cause of pain in this country. And not so arguably, but most definitely missed by most physicians. Most physicians could no more do an exam, a proper exam for muscle pain, than they could pull a motor out of a car. They just, the training in MD medicine for pain is dismal. The other thing besides for muscle pain and fatigue that you're going to see when you have a severe drop in energy is hypothalamic dysfunction. Hypothalamus is an almond-sized control center in the brain, controls pituitary, controls autonomic and hormonal function. It controls sleep. All three of these are on that same circuit breaker. And that circuit breaker, the hypothalamus, uses more energy for its size than any other area in the body. And that's why when energy drops below certain levels, it goes offline first, and indeed does act as a circuit breaker to protect the system. It basically takes people out of the game when they have an energy crisis before they can keep pushing and do themselves more harm. So we talked about tripping a circuit breaker called the hypothalamus. As we said, it controls sleep. So you're going to see most people, even if they can't sleep, they're going to feel that it's non-restorative. And part of this is hypothalamic dysfunction. Part of it also is the body has trouble shifting from adrenaline response to the vagal parasympathetic response. And staying in adrenaline mode all night, sympathetic dominant all night, makes for unrestful, non-restorative sleep. We see widespread hormonal deficiencies because the pituitary, which is controlled by the hypothalamus, controls sleep. As I mentioned, when it controls the thyroid, the adrenal, and reproductive hormones, as well as others. So you'll see widespread hormonal deficiencies despite normal testing. And especially important with COVID, it controls autonomic function. So what does that do for fatigue? When we stand up, we are a big bag of water. Blood is basically fluid. And what's gravity going to do? If you think about it, we stand up, all that blood should go downstream to our legs. And indeed, it does tend to do that. The autonomic system is what allows us to be an upright species. It has evolved so that the legs send the blood back up to the brain and the heart and the muscles and the other organs. But when that's not working, what you'll see is the blood goes down to the legs, pools there. It's as if you lost 2-3 units of blood very quickly. And the heart rate increases, pulse goes up to go ahead and accommodate for that. For those who would like, there's a information sheet that I've put together, a simple thing that you can give to those who treat. It's an orthostatic intolerance information sheet, which is autonomic dysfunction, POTS, NMH, whatever you want to call it. It will include a simple quiz in the Mayo Clinic Journal that is about as effective as a tilt table test for screening for orthostatic intolerance. There's also a 10-minute pulse test that people can do on their own at home. That if the pulse goes up from being horizontal for 10 minutes, then you stand up and you check the pulse every minute. If it goes up really more than 20 beats a minute, anytime during that 10 minutes, that suggests autonomic dysfunction and orthostatic intolerance. What you may see in post-COVID is that they haven't yet developed the pulse being able to adapt and compensate, and you may see a drop in the blood pressure instead. So that's not on the information sheet. But doing the 10-minute pulse, you can have your nurse do it or whatever, or have them do it at home and just check the blood pressure from lying down to standing and see how much that drops. So these are the things that are on the hypothalamic circuit. And as we mentioned, low energy equals tight muscles equals pain. So we had talked about fibromyalgia being the energy crisis, CFS the same thing, post-COVID the same. And what our published double-blind study showed, we looked at people with CFS and fibromyalgia. About half of cases of CFS, a little under that, are post-viral or post-infectious. So you get a pretty good mix of this in that total group. And again, the study showed that 91% of people with CFS and fibromyalgia using the SHINE protocol, which we'll discuss, had an average 90% improvement in symptoms. And that's p less than 0.0001 versus placebo for all of the outcome measures. For those who would like, if you email me, my email address is fatigue, F-A-T-I-G-U-E, and then D-O-C, like doctor, fatiguedoc@gmail.com. If you ask for the treatment tools, happy to send you the orthostatic intolerance sheet. You can ask for links to the studies, including the double-blind study. You can ask for a simple questionnaire to screen for each of the different most common causes, like thyroid or adrenal or candida, and a treatment checklist. All of these tools will make it much simpler, and we're happy to supply those for free if anybody would like. So in the study, outcome measures, number one, we asked them, how do they feel? Did they feel better or worse? Is much better, better, no change, worse, or much worse? And you'll see the black bars represent the active group. So half of the people felt much better, and another 41% felt somewhat better, but not the almost healthy kind of much better thing. And you'll see for the placebo, the usual kind of bell curve that you get. We did a well-being visual analog scale. And again, what you're seeing is at 3 months, there was a 75% average increase in function, which increased at 2 years to a 90% average increase in function. There's a validated scale of FIC, a disability index, and you see in the active group, dramatic drop in the disability scales. And as many of you are used to seeing, you're used to giving treatments that the person says, hey, I felt better for a couple of weeks or a month or two, and then they crash and burn again, because there are many weak links in this illness. And if you only treat one of them, the person will feel better for a little bit, but then it strains all the other systems and they crash and burn again. And that's why the comprehensive approach we're going to discuss today, we wanted to see, well, how long does the benefit persist? And it showed that at the 2-year follow-up, they continue to get better and better despite being able to wean off of most of the treatments. So this is a comprehensive protocol that makes a big difference. So as I mentioned earlier, I got into this when I had post-viral chronic fatigue syndrome in 1975. And, we all have to have something that gives us our joy and our pleasure. And for me, dedicating myself to making effective treatments available for everyone with this illness has been my passion. So we talked about take-home point number one. If anybody comes in with fatigue, you ask them one question that'll tell you if they have chronic fatigue syndrome. Can you get a good night's sleep? If they say, I can't sleep, I'm waking up 3 times a night, it takes me an hour or 2 to fall asleep. Even if I sleep, I feel like I haven't slept and it's non-restorative. Presume to have CFS and fibromyalgia. And this protocol in that setting will generally be very helpful. It's an energy crisis, and you optimize energy with the word SHINE. So write down SHINE. That is the acronym for getting people better. S is for sleep. H is hormone optimization. I would be infections, N is nutritional support, and E is just enough exercise to keep them from decompensating or deconditioning. If you push too much exercise, they can't condition to that point. They will crash and burn and be bedridden for 2-3 days. So it's exercise as able. So let's start by going through the evaluation and workup. You want to take a thorough history. And again, it can take you an hour just to go through all the questions to figure out the subgroups of problems that are going on. Or you can just have them fill out a checklist where they check off what they have. And you can scan through that in 5 minutes. And that will tell you, because you'll see thyroid symptoms, adrenal symptoms, sleep issues. You just scan right through and you see which one has a bunch of checks. And that's how you tell that they've got that issue. The testing won't do it. And again, I'm happy to send you the questionnaire. It'll be a short form questionnaire that just has the simple things for CFS and fibro. It'll have a treatment checklist. You know, if you're writing the same thing out over and over, take the thyroid, here's how you take the thyroid, here's how you dose it, and you're writing the same thing illegibly over and over, day in and day out for the different supplements, that's just grossly inefficient. Use a checklist and just check off thyroid. Okay, it's all typed out. They can read it. You know, check off the adrenal support. Check off, you know, here's for sleep. Here are the natural things. Here are the prescription things. Again, I'm happy to send you these questionnaires and the treatment checklist. Make it easy. For those who would like the long questionnaire, which is the complete intake, past medical history. Do you have any drug allergies? What are you taking? You can ask for the long form questionnaire also. And again, then feel free, this is in a Word document, so you can just modify all of it to your practice. So if you want to email me at fatiguedoc@gmail.com, ask for the treatment tools. Happy to send them along to you. Now, the labs are much less important than the history. And there's no test that I would use to diagnose CFS and fibromyalgia. You know, how do you diagnose it? Again, fatigue, yes. Can you get a good night's sleep? No. Do you have brain fog, widespread pain? Okay, you have your diagnosis. The diagnosis is easy. People can go on my website. There's a 5-minute questionnaire that they do. I'll tell them if they have CFS or fibromyalgia. But the SED rate, let's go through the key tests. The SED rate, simple, cheap, priceless. The SED rate, if it's, most people with this illness have a low SED rate, under 5. CFS and fibro tends to be low. If the SED rate is over 20, you want to start thinking of inflammatory or autoimmune diseases or severe infections. The viral infections usually don't do it for the chronic ones. But if it's over 20, you've got a subgroup. You want to look at autoimmune and inflammatory. If they're over 50, you want to consider polymyalgia rheumatica. And then do a CBC in chemistry, roll out, you know, I've seen people come with blood counts of 24 for the hematocrit, you know, and that people, nobody ever checked their blood count, even though they're bedbound. It's crazy. So blood count, chemistry, SED rate. For thyroid, the 3T4 is the main test. And again, you may, I don't know how many of you know where the normal range for blood testing comes from. You know, in medical school, I was given the impression that a group of wise elders with silver hair and snowy beards and, you know, who were the experts in medicine sat around the table and they said, well, if it's in this normal range, the person's probably fine, you know. And it was a shock to me to realize there was no such group, maybe a few of them put together by the drug companies. You know, whoever gives the most money to the medical organization seems to get to pick who sits on the committees for making the decisions of, you know, what standard of practice will be. But the way that the normal range is derived from most tests is 2 standard deviations. They take 100 people and the 95% of the normal, in the middle of the normal range, and the highest and lowest 2% are abnormal. To give a simple analogy for those I treat, is the normal range for shoe sizes would be 5 to 13. That would include 95% of the population. So if some 300 pounds, 7'2" Texan walked in with a size 6 shoe and said, my shoe's too tight, the doctor would say, the test is in the normal range. There's nothing wrong with your shoe. And that's pretty much an exact analogy to what's going on with how we use the testing in standard medicine these days, that the test is normal doesn't just means they're not in the lowest or highest 2% of the population. But if in the lowest 10% and they have symptoms, that's abnormal. But you already know this. Free T4, TPO antibody. If it's positive, it increases my suspicion. Reverse T3, if that's high normal, then they may need just a T3. And that's beyond the scope of this talk, but that can be helpful. TSH, when I was lecturing in Italy at the yearly fibromyalgia conference, one of the other speakers was a main researcher for thyroid disease and fibromyalgia. And I asked him point blank, is TSH reliable in fibromyalgia? And he said, absolutely not. Because again, with the hypothalamic dysfunction, the TSH is pretty close to being a meaningless test. But if it's elevated being 2.5 or higher, I will be more likely to consider trial of the desiccated thyroid. I will check a DHA sulfate. The B12, if the level is under 540, I'm going to treat. If the iron percent saturation is under 22%, I'm going to treat. If the ferritin is under 60. If you look at the research, a lot of people say if the ferritin is over 12, it's fine. And researchers that tend to be a pretty conservative group in their statements by and large. They may say, well, this suggests that maybe we should reconsider our position. No, in the study, one of the studies looking at the iron levels, the researchers said point blank that using the normal range for iron deficiency is, quotes, insane. Researchers don't use that language. But it is insane. If the ferritin is under 60, I am going to consider treating with the iron. Morning cortisol, technically, if it's over 6, it's normal. Again, if you're doing the cortisol in the middle of the day, it's just a random, uninterpretable result. It needs to be fasting and morning before 10 a.m. If it's over 6, it's normal. So if a person is bedridden with horrible symptoms of adrenal insufficiency and a 6.1, many endocrinologists will say, it's normal, no problem. If it's 5.9, they'll go, oh my God, you may have Addison's disease. But 6.1, no problem whatever. Most of us run about 18 in the morning. I've had the lab several times accidentally do 2 cortisol levels on the same person, same tube of blood. They just accidentally reproduced it. Having treated thousands of people, you'll see that. Usually they're 4 to 6 points apart on the same tube of blood for the cortisol level. So 5.9, life-threatening, 6.1, no problem. That's how standard medicine is addressing it. So again, if they have symptoms, and the best symptom we'll talk about it is, do they get irritable when hungry or hangry? And especially if the cortisol is under 16. I'm going to be suspecting and treating for low adrenal.
Recording in progress.
Okay. And then testosterone. Again, 70% of people with CFS and fibro are in the lowest 30% of the population. Hey, Seth, you just popped in there.
Hello.
Hello there.
How are you, Dr. Jacob? So nice to see you.
Good to see you too.
You.
So if the testosterone is the lowest 30% of the population, if it's under about 500, 550 in men, I'm going to treat. And even if it's low normal in women, I'm going to treat. And then again, I don't do testing for other infections because the testing is grossly unreliable, but there's sometimes that I will, but not routinely. So the testing is kind of what we just looked at here. Sleep. So let's take a look. We talked about SHINE. How do you get these people well? Sleep, hormones, infection, nutrition, exercise as able. So how do you get them sleeping? First of all, sleep is not just for energy. Sleep is for pain. This research shows if people are sleep deprived, you will get widespread pain. In people with chronic pain, if you don't get them sleeping, the pain won't go away. And they can't sleep because the sleep center is not working. So go ahead and you got to get them sleeping. And there are a lot of natural sleep aids. I like a mix of 6 herbs called the Revitalizing Sleep Formula. That's not available in a practice order line. There's a mix of 4 essential oils. made by Euromedica. It's called Terrific ZZZZ. It's very good. Melatonin, I'm going with higher doses now, 5 milligrams, but I'll even go with a 10 milligram sustained release. It's funny, there's some people who nothing will work for sleep and they give them 60 milligrams of melatonin and they sleep. A 5-HTP, even the smell of lavender, have them put a drop of lavender oil on their upper lip and the scent of the lavender will help them sleep. If they have a lot of pain at night, if the muscles are very tight, an Epsom salt bath, 2 cups of Epsom salts in a tub of lukewarm water. And that really can relax them, but have them take a half hour to cool down before they go into the bed because otherwise they'll sweat. Prescription sleep support. I know a lot of us don't like Ambien, but in terms of initiating sleep, the Z drugs, Ambien, Lunesta, Sonata, are the most effective. And for many of these people, they really need that. And you'll see, we don't see addictive issues if they're taking 12.5 milligrams or less. At 12.5, we sometimes start to see it. What you will see if they stop it suddenly is rebound insomnia. So you can't just put them on it for 2 years and then stop it suddenly. You want to decrease it 2.5 milligrams a night every 2 months and wean them off. Some people will sleepwalk, sleep eat, sleep drive, but it's a relatively small percent. Trazodone, 25 to 50 milligrams works very nicely. Gabapentin can be very helpful. We're seeing a big push now when the DEA doesn't like things. We suddenly see a bunch of misinformation come out. But Neurontin is quite safe, gabapentin, with the exception of people who are taking narcotics. If they are taking high doses of narcotics, it increases the risk of overdose death by 50%. But in people who are not taking narcotics, the gabapentin or high dose Valium, Xanax type things, the gabapentin is safe. Flexeril, anywhere from 2.5 to 5 milligrams. And if they're not taking antifungals or Cipro, then the Xanaflex, 2 to 4 milligrams, as high as 8, but usually 2 to 4. Any of these or in combination. So I start with the natural things. Then they will do better. People do better with a low dose of 4 or 5 things than with a high dose of 1. If you give them enough, their sleep problems are profound. If you give them a high enough dose to keep them out all night, they will be hung over till 3 in the afternoon. But each of these different treatments has its own half-life, which means it clears out of the body in its own speed based on the dose, regardless of what else you're taking. And that's arguable, but as an overall thing. So if you give low doses of 3-4 things, the effect is additive during the night. It'll keep them out, but they each get cleared out of the body on their own, and they won't be that hungover the next day. So an important principle, however you decide to treat sleep, natural, medication, or a mix, low doses of several things, especially if you're using the medications, the low doses of several things works better than a high dose of 1. For the hormones, the hormones are made by the glands, which are all controlled pretty much by the hypothalamus. And, the thyroid is like gas pedal, adrenal is the stress handler, the reproductive hormones are important for much more than just reproduction. And even mild underproduction can leave people feeling miserable. So again, remember we talked about the blood tests are based on, you have to be in the lowest 2% of the population, basically organ failure or gland failure to be abnormal. The testing is looking for complete destruction or just, severe malfunction. But when you have the hypothalamic dysfunction, what you're going to have is, maybe a 50% drop in the thyroid. As we mentioned, Professor Neek and Rydell's research showed that on TRH stimulation testing, thyroid stimulation testing, the TSH was still normal, but it increased on stimulation by only 50% of what it did in healthy people. Not enough for gland failure, but enough to leave the person miserable. So even mild underproduction, I know I'm preaching to the choir here, but you got to treat the person, not just the blood tests. And as you know, use bioidentical hormones. So thyroid dysfunction. You can almost presume that it's going to be the people with Cfs and Fibromyalgia. The majority of them are going to have underactive thyroid function One, because of the hypothalamic dysfunction. Two, they have the Hashimoto's is more common. Iodine deficiency, we've lost half of the iodine in our diet. People with fibromyalgia have difficulty converting the T4 hormone to the T3 hormone, which, by the way, that conversion is dependent on adequate levels of iron, another reason to keep the ferritin over 60. And a significant percent will have T3 receptor resistance. So what I'm going to say again is to go ahead and treat based on the symptoms. And I don't treat based on blood testing. That the test is in the normal range means nothing. But I will check, not TSH. TSH, you can expect it to be low if you're adequately treating in many cases. But you want to make sure the free T4 is not elevated, because if it's in the high normal, in the top 10% of normal, you can make the person worse, increase the risk of osteoporosis and such. So treat based on the dose that's optimal to the person, and then check the free T4 to make sure that it's not elevated or high normal. The T4 may be low with optimal treatment because the desiccated thyroid has T3 that may suppress the T4. Don't go chasing a low T4. If the person feels like the dose they're on is optimal and the T4 is not high, presume that it's optimal. Adrenal, the hypothalamic pituitary adrenal axis is off. You're going to see this routinely in CFS. You're going to see it in post-COVID. And again, the first thing I'm going to diagnose based on symptoms. One, the number one symptom, ask people, do you get irritable when hungry? And what you'll often see is the person who's with them is going to go, if they get irritable when hungry or hangry, you can presume the adrenal fatigue is present. Also, if they tend to low blood pressure or orthostatic intolerance, treat for the adrenal fatigue. I will begin with increasing salt and water. I will go ahead and use a supplement called Adrenaplex, you can get that from Euromedica, and that's a very good mix for this. And if I need to, I will use low-dose hydrocortisone, 5 to 15 milligrams a day. Now, again, we've been taught that hydrocortisone is toxic, and it is, but not in these very low doses. If you look at the literature, and it took me 3 years going through the literature before I was comfortable going ahead and using the very, very, very low dose hydrocortisone, you don't really see that most of the toxicity until you get over 20 milligrams a day, because the body makes 35 milligrams a day. So if the equivalent anyway, after absorption. So if you're giving 10 milligrams a day and your body does not want it, it will just make 10 milligrams less. It's when you go over the 20 milligrams a day that you start to see adrenal suppression. In our study we published, we looked at pre and post cortisone stimulation tests. Using these very low doses, we did not see any adrenal suppression. But when you go to 25 milligrams a day, you will start to see adrenal suppression. And most of the toxicities, the severe toxicities at 35 milligrams a day, you're going to start getting those. So I will use the hydrocortisone, the Cortef, but only if needed and only if they don't respond to the other natural treatments. Fungal infections, eye for infections. In my experience, the most important one to treat, certainly you have Lyme, you have a host of infections, but the number one most common infection to treat is Candida or fungal overgrowth. There's not any test that I consider reliable for that. If there's tests that you find helpful, that's fine. But I'm going to treat based on the symptoms. Because of the immune dysfunction, this is an opportunistic infection you can almost presume to be present in CFS and fibromyalgia. And how do you tell? If they have chronic nasal congestion, postnasal drip, if they get irritable bowel syndrome, gas, bloating, diarrhea, constipation, any of those, I'm going to treat for Candida. I will treat with probiotics. I will treat with a low sugar diet because yeast grow by fermenting sugar. There's a host of natural antifungals. There's a berberine met X, which is a nice problem. There are the tannins. There's all kinds of, I'm sure you probably have your own mix of natural antifungals that you like. But again, the berberine met X is one that I like. And I will use the diflucan 200 milligrams a day for 6 weeks. 1 to 3 days, unless you're treating just a vaginal infection, is not going to do anything for the Candida overgrowth. But you'll see about 5 to 6 weeks into the diflucan, you will go ahead and find that their chronic sinus stuff is starting to clear up. Their irritable bowel syndrome is going away. Their brain fog is starting to clear up. And there are times I'll even go to 8 to 10 weeks. I've never seen worrisome liver inflammation. You'll sometimes see a bump in the liver enzymes, but again, that tends to be transient. I don't check the liver tests unless they're taking it more than 6 weeks, and 6 weeks is usual course. Again, if they're taking Cipro, if they're taking statins, if they're taking Xanaflex, that's a drug interaction that can raise the levels. So I usually will leave those off while I'm giving the diflucan. The mold toxins, which is very different than mold infection, is present in a subset of these folks. Mostly it's going to be people with severe, horrible anxiety and severe sensitivity to everything. You can't even give them melatonin or an herbal because they get the horrible reactivity. In those cases, I will consider mold toxins, but that's a whole nother talk in itself. So in most people, I will treat for Candida. For those with a chronic sinusitis, there's a sinusitis nose spray that compounding pharmacies, I use ITC Pharmacy for that, can make. That along with the diflucan, you'll see these people with chronic sinusitis that after the 12 weeks of the spray and 6 weeks of diflucan, 8 weeks, goes away, makes a major difference for them. Other infections, there's a host of viruses. For those who had a viral onset, they had what I call the drop-dead flu, and they have chronic flu-like symptoms. The combination of Famvir, 500 to 750 milligrams, given 3 times a day, plus Celebrex, 200 milligrams twice a day. This is research by Dr. Pridgen, Pridgen, showed a quite significant improvement after 4 to 6 months on the combination. The Celebrex, interestingly, is an antiviral. It's the only NSAID that I've seen that's on the market that also has the antiviral properties. It augments the Famvir. I find the Famvir much more effective than the Valsite for this issue. A small percent of people will have enterovirus, although it could be more than that. But if they have predominantly gut symptoms at the onset, there's an herb called equilibrant, but it's not an easy one to take. It can cause a significant die-off as the immune system shifts. Lyme, you folks are probably already very familiar with Lyme. And how to treat it, again, that's a whole nother talk in itself. The testing I consider unreliable. I will treat based, if I have a clinical suspicion, I will treat. But here's the key thing, is that once you've treated the Lyme, you're going to find a lot of people will have persistent symptoms. And that's because the Lyme has triggered a secondary fibromyalgia. If you don't treat the shine, you're going to find what happens is you give the antibiotics, and each time you raise the dose, they feel better. But what's happening, it's a funny, I don't know why, but the antibiotics seem to suppress the yeast dying off and causing symptoms. And they will get better, and then you get Candida overgrowth, and suddenly they're going to get worse. You push the antibiotic, which seems to suppress the yeast dying. So it doesn't suppress the yeast, but it suppresses the symptoms. And you go with higher and higher doses. And if you simply add the shine protocol to the anti-Lyme, and especially treat the Candida, if you've been treating with the antibiotics, they will often, suddenly they're going to find their Lyme symptoms. You've treated the whole picture now, and they're getting better. And you'll see parasites. Basically, the immune system is functioning poorly in this disease. So you're going to see a whole host of processes that are going on. Viral infections, again, suspect the blood tests. I will check them, but you're looking at the IgG. The IgG positive just means they had it. But if it's very high, if it's 640 or 1 to 640 or higher, or if it's over 4, For the IgG antibodies, I will consider viral reactivation. But mostly, again, onset with a viral infection, chronic flu-like symptoms, and marked autonomic dysfunction, orthostatic intolerance, low blood pressure, dizzy and standing, I'm going to treat with the antiviral protocol. And again, it's 4 to 6 months. So there's different titers that can be used. I mostly, again, will use the Famvir 500 to 750 milligrams 3 times a day for 6 months, plus Celebrex 200 milligrams twice a day. The dose on the Famvir could be the 500 or the 750, doesn't seem to matter that much. But the Celebrex, Dr. Pridgeon is saying that if you go with the lower dose than the 200 twice a day, it doesn't work. And again, a lot of what we call Lyme, I suspect is also, there are numerous antibiotic sensitive infections. And most of these we have no tests for that are useful. And we're just fooling ourselves with the testing. What I would rather do is I'd look at the clinical symptoms. If they are suggestive to me of an antibiotic sensitive infection, I will treat. But I'm not going to label it a specific name. I'm going to say suspected antibiotic sensitive infection. And I suspect that if they have low-grade fevers, even 99.5, most people are running low temperatures with the hypothalamic dysfunction. You'll have people who come in and say, you know, I had this antibiotic for dental work or for whatever, and for that week, my chronic fatigue syndrome went away. And I say, well, the doctor put you back on it long-term, right? He said, no, I couldn't get it. It just blows my mind. And those people are housebound and they're crippled and they took this antibiotic. And the doctor said, no, we're not going to do that. And I can only imagine they go in the next thing and say, I've got acne. Oh, yeah, here's a year of doxycycline. You know, it's just, we have an understandable hesitancy to use excessive antibiotics. But in these crippling diseases, if they have low-grade fevers, if they improved in the past dramatically, the Cfs fibro with an antibiotic, I'm going to put them on that antibiotic. And I'll give it to them as long as they need it. And I will cover them with the antifungals, 200 milligrams twice a day, 1 day a week of the diflucan to prevent Candida overgrowth. The other thing you'll see is people who come and they say, do you have any drug allergies? Yeah, I'm allergic to amoxicillin, Cipro, doxycycline, and they may give 1 or 2 other antibiotics. And I say, how about anything else? No. It seems really unlikely that with these 5 antibiotics being chemically unrelated, that they would be allergic to these antibiotics or pick the antibiotic that you want and not anything else. That suggests that it wasn't really an allergic reaction. It was a Herxheimer reaction, and that they have something that they're herxing to that's antibiotic sensitive. So I will consider in those cases starting with really tiny doses like doxycycline, 25 milligrams every 4 days, and just start them really low. If they have chronic scalp sores, it's funny, we don't know why, but those people seem to improve with Zithromax. If they have chronic lung congestion, I will also go ahead and consider the antibiotics. That suggests an antibiotic sensitive infection. And people who had vertigo, not just a 6-week course, but they started the CFS fibro with vertigo, they have chronic vertigo. Vertigo is not common in CFS and fibromyalgia. It was popularized with Laura Hillenbrand. And dizziness is common, but not true vertigo where you feel like you're spinning in a circle. That to me suggests an antibiotic sensitive infection. And I will go ahead and give doxycycline, Zithromax, or the other antibiotics as a therapeutic trial. We talk about the reasons for the nutritional deficiencies, increased nutrient losses as well. But I don't do much testing except make sure the ferritin is over 60 for the iron. I don't want it much over 100. B12, 540. If it's under 540, I'm going to treat. But there's vitamin powders, there's clinical essentials. Clinical essentials is very good, but it's low in zinc, so I supplement zinc with that. But find a good multivitamin that has about 25 to 50 milligrams or more of each of the B vitamins, at least 100 of B12, preferably 500. I like 15 of zinc, 200 micrograms of iodine. Selenium. Selenium can increase diabetes risk. It's not massive, but it's about 55%. It's significant. It's significant, but If that happens at 55 micrograms a day or more. So if they have Hashimoto's, I'm going to give 200 micrograms of selenium. But otherwise, I prefer a multi that has about 55 milligrams. And I like the vitamin powders, but there are a number of very good ones. Again, Clinical Essentials plus zinc 20 milligrams is a very good multi. It'll have B vitamins, it'll have the minerals, it'll have the magnesium. Magnesium is critical. Also, nutritional advice, there's no one diet for everybody. See what leaves them feeling the best, but most of them will find that increased water, increased salt. You salt restrict with chronic fatigue syndrome, you'll crash and burn. They need to decrease sugar. And most people do better with a high protein, low carb diet. In terms of other nutrients, I'll give acetylcarnitine just for the 3-4 months, 1,000 milligrams a day. I will give there's something called Smart Energy System or D-ribose. And that's very, very good. And I'll give 5 grams 2 to 3 times a day, makes a 61% average increase in energy. The coenzyme Q10, I've actually switched now. Euromedica has a 100 milligram chewable tablet, which has gamma cyclodextrin, which means that it increases the absorption 7-fold. So the one tablet is like 7 tablets of CoQ10. I took that myself and I could feel the difference immediately. So I'm switching to the coenzyme Q10 chewable tablet by Euromedica. And the fish oil, I'm going to use Euromega-3 because, again, you want to decrease the pill count. 1 Euromega-3 is equivalent to about 7 fish oil pills. I'm going to skip through the D-ribose. We have a good bit to cover yet. D-ribose, again, we found a study, 61% average increase in energy in a multi-center study. I take that myself, just 1 5-gram scoop each day. I'm going to skip the recovery factors because that's not going to be available in the United States for another 3 to 6 months. But we've had 2 published studies now showing a pretty dramatic increase in energy and overall well-being. If you want any of these studies, the recovery factor study or the ribose, the smart energy, no, smart energy hasn't been published yet, so I don't have that. And again, you want them to walk enough to where they feel good tired after. Otherwise, you're going to decondition, but not so much as where they get wiped out the next day. Tell them to start slowly, increase by 50 steps a day every couple of days, see what feels good, leave it there for 12 weeks. After 12 weeks on the SHINE protocol, energy production will skyrocket, then they can begin to condition. So just a few slides on specific post-COVID-19 specific organ injury. Number one, these people with who have long COVID, orthostatic intolerance is real common and can be debilitating. And as I mentioned, if you email me for the orthostatic intolerance information sheet, there'll be a quick quiz. There's a 10-minute pulse test, but also check their blood pressure lying down and standing up. If it's dropping more than 10 millimeters with a long COVID, they probably have the orthostatic intolerance. The sheet will tell you how to treat it. It's not hard. There's plenty of things you can do. There's much that can be done for it. But again, start by increasing water and salt intake. And they're going to say that I'm already drinking like a fish, but tell them that the hypothalamic dysfunction, they have antidiuretic hormone is low. They're drinking like a fish, but they're peeing like a racehorse. They need water. They need salt. Optimize adrenal function, like the adrenoplex. There's, compression stockings. They need to be medium pressure, 20 to 30 millimeter. The knee highs help a bit, but the thigh highs help even more. And again, if you want the information sheet, it summarizes all about the orthostatic intolerance. You're going to see that much of the ongoing injury post-COVID is oxidative injury. You have free radicals, you have inflammation, those two. I will use a clinical glutathione to shut off the oxidative stress. Again, glutathione is the main antioxidant of the body. The NAC, 1 gram twice a day, is a good way to do it too. It's cheaper, but right now the NAC, N-acetylcysteine, is just very hard to find for some reason. Make sure they have a good multivitamin with antioxidants. And I'm going to put everybody with post-COVID, I'm going to put everybody with cancer. I'm going to put, the curcumin, most curcumins are poorly absorbed The one that I'm going to use is called CuraPro, where it has the turmeric oil added back in, the turmerones. It increases absorption 7-fold. This is what most of the research that on clinical is being done with the CuraPro, the cancer research, the arthritis research, the depression research. I'm going to give the CuraPro 1,500 milligrams twice a day for post-COVID, or at least 750 milligrams twice a day. I take 750 milligrams a day myself, even though I feel great, just because the health benefits are just so pronounced. You want to support decreased coagulability. Fortunately, even if they had a thrombotic event during the COVID infection, the risk of a repeated severe thrombotic event is low afterwards. But I think it's a good idea to be on omega-3. Again, the Euro omega-3 is what I use. Maybe a baby aspirin, ongoing for a while to help keep the thrombotic tendency down. Cardiac injury. You're going to see many people, a lot of people have chronic shortness of breath, but most of them don't have heart or lung problems. It's not low oxygen, but it's a sense of air hunger. It's feeling like they can't take a big enough breath. And here's the thing, that if you have somebody complaining of shortness of breath post-COVID, they need to get a pulse oximeter. It's simple. You can get them for $25 on Amazon. And this way, when they're walking around, if they get the shortness of breath, if their oxygen saturation is staying over 95%, it is not coming from cardiac or lung issues. It's a sense of breathlessness, but they're getting plenty of oxygen. And if they can know that, it's very reassuring for people. But if they do have cardiac injury, the oxygen levels are dropping. They have, the doctor, the cardiologist is checked and they have cardiac injury. There's a phone app called Cures A to Z, C-U-R-E-S, capital A to C. It's a free phone app. Most of the information is in the free app. There's a $2 upgrade. All of this, if you look up heart disease, anybody with heart disease, this recipe increases the efficiency of the heart muscle dramatically. I've seen people who with end-stage CA, chronic congestive heart failure, 2 months later, they're just better. And they were told they were going to die, and it was resolved. So magnesium, if kidney function is okay, B complex, these two are the core for energy production. The coenzyme Q10, and I'll go to the chewable because you get higher levels. The ribose, 5 grams 3 times a day, increases cardiac muscle efficiency. And the acetylcarnitine, a gram twice a day. This recipe, if they have cardiac injury, myocarditis or other cardiac injury, causing, contributing to the post-COVID, this simple recipe is just, again, Cures A to Z phone app. Download the free app. On most phones, you can get it. And just look up heart disease, the recipe will be right there. And then for even more intense, it'll talk about magnesium aspartate. It'll talk about hawthorn and other things. For the cognitive dysfunction, again, a lot of that is just the post-viral Cfs and Fibromyalgia, but microglial activation is a major trigger. There's some who had mini strokes from the coagulopathy, but if you find most of these, 79% on autopsy, have microglial activation. Treat them with a low-dose naltrexone, 3 to 4.5 milligrams, at bedtime. It may disrupt sleep, so most of you probably know how to use low-dose naltrexone. Start with the starter pack, but don't forget the low-dose naltrexone. And then there all these other treatments in the SHINE help the cognitive dysfunction. And then the pulmonary fibrosis, again, if they were in the hospital with pneumonia, more likely, then the shortness of breath is probably coming from that or the cardiac. Reassure them, number one, that in shock lung, the ARDS, the studies have shown in different diseases that cause that, it usually heals itself over 2 years. It's going to get better. Number two, use the pulse oximeter, as you mentioned. Use the CuraPro, the curcumin, because all of these things help the healing. And again, if you would like the free practice tools, email me at fatiguedoc@gmail.com. If you'd like this PowerPoint file, you can ask for that too. We're happy to send it along to you. Here's my book, wonderful book, yay, blah, blah, blah. Anyway, so I want to thank all of you for joining us today. I'm happy to stay and take any questions that you have. The SHINE protocol was reviewed in the Journal of the American Academy of Pain Management, and the reviewer noted that the SHINE protocol is an excellent and highly effective part of the standard of practice for treating fibromyalgia. Fibromyalgia is very, very treatable. What's missing is not lack of effective treatments, but lack of physician education. So I'm hoping that what you have today will give you enough to get these people feeling dramatically better and to give them their lives back. And thank you for being here. Happy to take questions, William.
Thank you, sir. Well, let's see, what do we have in the chat? What is the yeast Candida test that you prefer?
None. There's no test that I would give a nickel for. The test that I use is, do they have nasal congestion, postnasal drip, or sinusitis, or or do they have symptoms of irritable bowel syndrome, gas, bloating, diarrhea, constipation? If they have either of those in fibromyalgia, I will treat for the Candida. It's a clinical diagnosis.
Right. Not one of the questions, and maybe just a comment, but I found that those with chronic sinusitis that have been treated multiple times with antibiotics frequently have some sort of fungal component.
Well, let me adjust that, William. A Mayo Clinic study showed that well over 90% of people with chronic sinusitis were having immune reactions to fungal elements in the sinuses.
Yeah.
This has been shown in the research, not sometimes, but the vast majority.
Okay, so we've used a combination antifungal and with a steroid. Is that pretty much what you're doing also?
Steroid nose spray. There's a sinusitis nose spray that's a mix of the steroid, the diflucan, the Bactroban. You can add bismuth and xylitol, and it kills the infections. It's very benign. ITC Pharmacy makes a good one. Most compounders can, but they don't buffer it right and it burns. So the ITC doesn't. If you want, when you email me, I can give you it's just called the sinusitis nose spray from ITC Pharmacy. They'll mail it to people if you order it for them.
Okay.
And
okay, the next question. Do you have an approach to Epstein-Barr virus?
Yes, that's the Famvir Celebrex. Works very, very nicely for that. Famvir 500 to 750 milligrams 3 times a day, and the Celebrex 200 milligrams twice a day. Interestingly, Pepcid or Tagamet both modify immune functions in ways that are very, very helpful for getting rid of the chronic Epstein-Barr. So that's Pepcid or Tagamet, where the other PPIs like Nexium and the little purple pills, those are deadly. I will not prescribe those for people except for rare exceptions. But the Tagamet and Pepcid can be very helpful. So this is a combo, but for the antivirals, you're looking at 6 months as a therapeutic trial and 4 months to start seeing their benefits, although adding in the Celebrex has been much quicker than that.
Okay, great. Okay. And mostly attaboys and fabulous lecture. Do you recommend ubiquinone versus ubiquinol?
With the chewable coenzyme Q10 that Euromedica has, that increases the absorption. Other ones you get modest increases in absorption. It was a toss-up of the increased cost justified ubiquinol versus ubiquinone. At this point, that the whole conversation is moot. Using the gamma cyclodextrin, we did one study using an HRG80 red ginseng that I should mention here. It's red ginseng energy. That's also, Euromedica makes some very good stuff. No, I'm not on their payroll, but they just have really good quality stuff. And they have one of the studies that we had published, I can send the link for the study, dramatic increase in energy. We use the capsules or the chewables. And what we found was a similar effect from the 100 milligram chewable as with the 400 milligram capsules, which drops the price 60% for people. That's what I take myself. It just, that's funny. If I have a busy day like today, this isn't not the practitioner line. This is HRG 80 red ginseng in the consumer line, but you can get it as red ginseng energy from Emerson Ecologics, and it's quite. But because it has the gamma cyclodextrin added to the chewables, and I get the chewables, the effect is dramatically better. I'm really impressed with the gamma cyclodextrin. So for the coenzyme Q10, I will use the chewable that has the gamma cyclodextrin, and I think your Medica has it. I know your pharma has it, and that's what I use. And the one a day, the 100 milligrams a day is like 800 milligrams of CoQ10.
So we've had Dr. Yutani here and Dr. Patel from Central Drugs, and they have their glutathione with the cyclodextrin in too. Is that?
I haven't tried that one, but again, the gamma cyclodextrin, in terms of decreasing pill count and increasing absorption, you look at a 7 to 8-fold increase.
Actually, I have it actually here. It's a transdermal actually.
Yeah. So I don't have experience with that, but William, you do. So let people know. And
okay. So and that lecture is in our webinar thing on our website. So you can go back if anybody wants to go back and listen to it. It's on our website, p.org/webinars, and look for Dr. Yutani, Yutani, and another shameless plug. He will be with us also.
Another shameless plug.
Hey, I gotta get my digs. We got a week to go here, and I can't wait for it to be over. If you want to know the truth, so how do you assess the antibodies for Epstein-Barr to decide treatment?
I don't.
Or do you?
I don't. Over 95% of adults are going to be positive, and the IgG antibodies for Epstein-Barr, for CMV, HHV6, these are just normal infections that most people have. There is a sheet that I have that will give what the 50th percentile is for the VCA, for the different antibodies. But, at the end of the day, I'm fooling myself, even doing the blood testing for these things. What it boils down to, they have chronic flu-like symptoms. They had onset with a viral infection. I'm just, at this point, I do the test just because I guess I need to do a test. But at the end of the day, if they have chronic flu-like symptoms, onset with an acute viral illness, I'm putting them on the Famber and Celebrex, period.
Okay. That's all the questions I have in the chat. Anybody else have any questions or comments? So Dr. Burgess, you must have something for us.
Yeah, I do. I was just wondering, with Dr. Teitelbaum's experience, if he's seeing any more Guillain-Barré in the last few years.
Not really. It's a funny thing, we expected a whole slew of it coming from the COVID and the vaccines. I haven't seen a case of Guillain-Barré in decades. But John, again, as William is asking for questions, this is not the game show Jeopardy where everything has to be put in the form of a question. Please, I invite all of you to teach too. If you have something here that you find really helpful, I'm going to invite you to throw it in. John, what do you find most helpful in treating this population?
Well, I was just considering the demyelinating polyneuritis. And if you're seeing more of that, because I think there's more talk about it. And I had Guillain-Barré about 10, 20 years ago. And that's why I can't remember if it was 10 or 20, because I had Guillain-Barré. my brain works differently. But I think we're seeing higher numbers than the textbooks would point to. They'll say 1 out of 100,000 and 1 out of 1 million for the Miller-Fisher syndrome. But if you have 10 to 20 cases in a town of 100,000, that's something else going on. And I'm not sure what that is.
Yeah, we're seeing stress on the immune system that's unparalleled in human history. And we're seeing ignoring the underlying causes also unparalleled because they threaten financial interests. So there's a lot going on, and then it's not going to be talked about unless there's an expensive medication. What we are seeing is increase in small fiber neuropathy. that seems to be associated with immune dysfunction, specifically IgG1 and IgG3 antibody deficiency, and autonomic function. These are all three phases, I think, of the same process. So I'm not seeing the Guillain-Barré, but we are seeing small fiber neuropathy. The IV gamma globulin can be helpful. The recovery factors in one of our studies that increased the IgG antibody levels 14% on average in people with deficiency. So that's something that, again, when it's available in the US, is very powerful in terms of the benefits we're seeing. But again, I'm not surprised that, John, that we're seeing a whole lot of more autoimmune and immune-related illnesses. That is for this generation. That's the big epidemic.
I know when I heard you with Dr. Hertog several months ago, you mentioned a little bit about, patient comes in and how you sort of evaluate them. I know you gave us your plan here, but could you give us a little bit of, because you mentioned that you spend 3 hours with them
I'm very efficient. And again, this is a complex multi-system disease. And the nice thing about the treatment checklist is it will gather a massive amount of information. And again, I use a long form that I have that you're welcome. You can ask for the long form intake. But for most of you, what you'll find is the short form that just takes each of the things we talked about and in categories. Do you have symptoms of this? And all you do is you scan down, you see where there's a bunch of check marks and what the category header is. Thyroid symptoms, all these check marks. Yes, you got that. And you go through the different ones. And that's just a quick way to do that. People can go online. There's actually, it's called energyanalysisprogram.com. There's a free quiz they can do. They can even enter their lab test, the pertinent lab test, as well as the symptoms. And it will give them a printout. You can just tell them to do it and bring it with them. And it'll screen for pretty much all the things, the key things we talked about here. That won't screen for the orthostatic intolerance, I don't think yet. But it'll tell, do they have Candida? Do they have a thyroid? Do they have adrenal? What are the sleep issues? And it's just a computerized doctor. I actually hold a US patent for computerized doctor that I made for people with chronic fatigue syndrome. It's free, it doesn't cost anything. People can just go online and do the quiz, energyanalysisprogram.com. Have them bring it to print out. It'll say, here's what's going on, and fill in the treatment checklist. Here's what to do to get well. It'll include both medications and natural options. As I say, my goal is effective treatment for everybody. One of the tools for that.
And I have to say that you're very generous with your knowledge and your all of the sort of proprietary things that you've come across that you use. When you were with Dr. Hertog and you said asked you for and you sent me the that package of information that you have, and I would highly recommend it for everybody. And then I realized I had gotten it almost 20 years ago from you also. I had the same, it's upgraded, but I said, this looks familiar. And I found it, in the back room somewhere. Sorry about that. but
you're ready for it when you're ready for it.
Yeah. But I said I'd had that a long time ago. Like I said, I found your book. It must have been in the late '90s or early '90s actually, just the title alone was sort of like sort of an eye opener. So, someone asked about your opinion on medical marijuana and CBD.
If you like it, use it. How do they say? Smoke them if you got them. So it's very, very helpful. I think that the whole issue is one of politics and economics. And, once you strip out all of that, then it's a matter of, it's safe. How does it work for you? Are you overdoing it? Common sense. It can be very helpful for people.
Okay. So when you run across some things like, in chronic fatigue, you mentioned infections. Is there a certain protocol that you follow to certain laboratory studies you do, certain labs you use, or just sort of like the instinct?
I treat clinically. The labs are near useless. They are not reliable. If you want to, you can get some to fool yourself and make yourself feel like, well, I see something in black and white here. They don't mean much. Do they have an onset of their illness with a viral infection? Do they have chronic flu-like symptoms? You know, and the answer, yes, I'm going to go ahead and put them on Famvir and Celebrex, as well as the immune and the overall things. Do they have chronic low-grade fevers? Do they have lung congestion? Do they have a history of allergies to multiple antibiotics? Do they have a history that they took an antibiotic and the CFS went away? Do they have scalp scabs? If they have any of those, I'm going to consider a trial of antibiotics, beginning with doxycycline or Zithromax and going from there, or beginning with whichever antibiotic made them feel better in the past. Lyme disease, to me, that falls, I mean, certainly if they have the bullseye and the rest, but that falls to me under the, antibiotic sensitive infections. Do they have vertigo? Do they have, if you have a clinical suspicion of Lyme, treat for it. That's how you're going to tell if they have something that's antibiotic sensitive. Parasites, high IgE, high eosinophils, if they were, and tromping through the third world jungles or something when they had the onset. This is really much more common sense. This is the art of medicine. It's just listening to the person. You've been so trained to ignore the art of medicine in exchange for testing. But to give you an idea of the testing, cholesterol readings, which I think is a whole nother scam. A study just came out this week, meta-analysis showing that statins decrease death rate by 0.8%. Now, to put that in perspective, research shows that eating a little square of chocolate each day is associated with a 45% lower risk of death during the study period. Owning a cat is associated with a 30% versus lower risk of death versus less than 1% for the statins. When I first started medicine, I would do a cholesterol panel and a chemistry panel on each of my patients. And these are using major national labs, one of the two major national labs, I won't say which one. And I found that the cholesterol reading, because each panel had one, was routinely 20 to 160 points different on the same tube of blood. And I said, this is odd. So the next 20 people coming in, I wrote down both readings of the cholesterol on the two tubes of blood on the same person. And they were just literally not uncommon to be 100 points different. I said, this is odd. And I called the pathologist, the lab manager in charge of the lab. I said, you got a problem. And they fixed it immediately. God bless them. From that day forward, when I ordered both panels, they suppressed one of the cholesterol readings. That is in black and white, doesn't mean shit. Sorry. Listen to your own art of medicine. It's time. What's your gut instinct telling you? Give the person 10 minutes, they'll tell you what's going on. Your instincts already know. And sometimes we have tests to confirm. But when we don't have reliable tests, it's okay to say, we don't have reliable tests. So I'm going to go based on the clinical evidence and see how they respond to treatment. Radical concept called common sense. So forgive me for teasing you, but it's just
no, that's fine. So so let's go to the hormone realm. So the H there. Some of my colleagues insist that they do saliva tests, and those are the only ones that are reliable. Some have a urine test, and that's the only one that's reliable. And where I am, the state of Nevada doesn't like any of those, so they make us do the serum tests anyway. I actually got pretty comfortable with them. I'm fairly confident what we're doing with it. So do you have any comment on the types of tests at all?
Each of them was just different things. If you look at the salivary reproductive hormone levels versus the blood reproductive levels, versus the urine, you're going to get three totally different things. They're measuring different compartments. There are many different things that affect the levels. So I think, if it makes you feel better to have them, they are helpful. But I still find that the most helpful thing is, are they tired, achy, weight gain, cold intolerant? Sounds like low thyroid. Let me give them some thyroid. They feel much better. They have low thyroid. I will take that over any test. Do they get irritable when hungry, have a tendency to orthostatic intolerance, have frequent sore throats? I'm going to give them adrenal support and see if they get better. And if the ASI is showing low, or, I find that most helpful at nighttime if they can't sleep, if they have trouble falling asleep because their mind's racing and the ASI is high at nighttime, the salivary adrenal, then I'm more likely to give phosphatidylserine. But even for that, if they tell me that I can't fall asleep because my mind is racing, I'm going to say, get a bottle of phosphatidylserine, spend the $10, take 300 milligrams 90 minutes before bedtime and see if you fall asleep more easily. So I can do that, or I can do a test. So forgive me if I'm a bit of a curmudgeon. It comes to the gray hair. John, I bet you and I on a bottle of tequila would have great fun being
Yeah.
curmudgeoning.
John pretends to be a curmudgeon, so.
You know what? I'm cleaning out my office all day long, and I was coming across papers and stuff we were doing 40 years ago. And man, it goes fast. And I don't know how much progress we've made with common sense and natural medicine. A lot more than I predicted, I think.
So, okay. Someone is asking about Arterisol HP for patients with cardiovascular disease.
I have no idea what that is.
Okay, I know it's a combination. It's an herbal remedy. Kent, you know what it is? You asked the question. Are you there? Ken? No?
He said it's
Yes, I am. Sorry, I was on mute. It is an herbal concoction, and essentially what it does is it repairs the glycocalyx, which is the inside surface of all of our vessels that we kind of ignored for a long time. Mark Houston has been a big proponent of its use. In the patients that I've been using it on, I've seen an average of 11 to 15 millimeters of mercury drop in diastolic. I've only been using it in patients for about 6 months. I don't have any with cardiomyopathy, so I haven't seen the profound observations that some of the cardiologists have seen, but I was just wondering if you had used this in your patient population that also has cardiovascular disease, because it's profound.
I haven't done that, but again, that whole area of treatments is, I think, potentially very powerful from what I've heard so far for endothelial function, for the blood vessel health. But when you're looking at the cardiomyopathies and a lot of these other things, the issue is a heart muscle efficiency. So if it's an issue of heart muscle efficiency, arrhythmias, things like that, I'm going to be going more with things that increase energy, the ribose, B vitamins, magnesium, acetylcarnitine, CoQ10, that kind of a mix. For the vascular, I don't know that specific product, but I'm with the class of agent that you're talking about for the endothelial function. I think that potentially can be very, very valuable. So when you're looking at the heart, it's not a homogeneous organ. It's, you have the muscle, you've got the vessels, you've got, the different aspects that need to be addressed. Does that answer?
Yeah. I just think it would be valuable for you to take a look at it, and I'd love to hear your opinion.
Thank you. Yeah, given that family of agent, I think it's, in Europe, it's a medication. But for the endothelial function, I think it's very promising.
I'll get it. Hang on. All right. Sorry about that. Wasn't me, but go ahead. You still there, Dr. Teitelbaum?
Oh, I'm here, but
okay.
But that was kind of what I had to say, and I don't have that much experience with it, but I think it's promising for a category of a nutrient.
Okay. And so on that, so I'm going to tag team on that note. There's a lot of nitric oxide proponents. Any experience with that? Any thoughts on that?
It's nitric oxide is such an ubiquitous system in the body, and so many things that help nitric oxide help other factors. The main way to address the nitric oxide directly is with arginine, but the problem with the arginine is that it feeds the whole herpes family of viruses, and I because of that, I'm not really comfortable, even in the vitamin powder that I use is low in arginine. I don't go after the nitric oxide specifically, because the other things that I do will tend to take care of that. I will give a caution for those who are taking lysine. I don't recommend lysine to suppress herpes outbreaks in the CFS and fibromyalgia population, because it suppresses arginine. Arginine is critical for growth hormone production, and low growth hormone is common in CFS and fibro. So it's one of the few times I'm going to go with the medication, the Famvir or the Valtrex, over the lysine. Want to be careful with things that suppress arginine for a number of reasons. For cardiac function, I don't play with nitric oxide that much, just because you're going to impair that other system, and I find other approaches.
Well, we're going to have one of them as our vendors next week. So just asking.
Don't tell.
Also, how about NAD also?
I don't use it myself, but it sounds very promising, especially using the intravenous NAD. The NADH is helpful in a small subset of about 20%, especially people with orthostatic intolerance. But those that it helps a lot. Because my population is from all over the world, I don't do the intravenous therapies that much. But I think the NAD is, from what I've seen and heard, is very promising. And for those of you that are giving intravenous therapies, I think certainly reasonable to consider that.
Okay, and it's one of our newcomers here in the chat. It's kind of a statement. I'm not as familiar with this type of medicine, but I'm concerned that anyone would give thyroid medication just because they had thyroid symptoms. I've seen doctors do this in the past and ignore other significant etiologies. I'm sure it's frustrating to test things and not find something wrong, or just assume the labs aren't reliable. But I think too much gestalt is scary. That's a quote unquote. Marrying gestalt with data seems like it's less of a faith-based jump for patients.
Well, the thing is that I appreciate and respect what you're saying, and it's just the different styles. There's no right or wrong with it. But again, I agree with what you're saying, that if somebody comes in and says, I'm tired and have weight gain, to just throw thyroid at them. I think you need to do a more comprehensive analysis. Do they have insulin resistance? Do they have other issues that are going on? But on the other hand, to rely on the thyroid tests that have been shown to be unreliable, especially in a patient population with hypothalamic dysfunction, to say that we will not treat, despite the research showing that this problem is very, very prevalent and common, and despite the research showing that the blood tests are grossly unreliable, is really also not evidence-based. Then what you're saying is that without definite proof, it absolutely doesn't exist, where scientifically, without definite proof, we don't know from that if it exists. And then we need to look at the next thing, which is, okay, what's the probability? This is a high risk population because of the hypothalamic dysfunction. So there's a high probability, which then increases the likelihood of success with the treatment, and alters a whole risk benefit assessment. And then you treat and you see if they get better, and they feel dramatically better with it. So the question is, if you don't have a test, if I'm going to play devil's advocate, say we don't have EKGs yet, we go back in time, but we do have nitroglycerin, and you're a doctor working in those days, and somebody clenches their chest, breaks into a sweat, has pain going down their left arm, and falls to the ground with crushing chest pain. Are you going to wait for the EKGs to be developed in 20 years? Or are you going to give them a nitroglycerin tablet while you are doing a more thorough assessment, looking for dissection and other kind of things that may be contributing? So there's no right or wrong with this. But the thing is to say that if there is no test that's reliable, we can't treat, and we ignore the patient because they're just a person talking. And especially when the objective evidence has been shown to not be consistent. As I mentioned before, the blood tests are not consistent on the same tube of blood. Then, when it comes time to do the CLIA testing, they will make sure that that tube is done properly. But otherwise, a lot of this is just that it's in black and white and in print. We'd like to think that makes it truthful. It's not. So the bottom line is there's no right or wrong with it. I invite people to do what feels the best for them. But this is what I found after my 45 years in medicine, is that I'm going to listen to the patient first. I will look at the reliability of the test. But if you don't have reliable tests, then I will go ahead and look at the probability of the illness in that population, the risk of the treatment, especially if it's low, and see how the person does. But again, I'm not saying my way is the better way, it's just a different way. And I invite people to do what feels best.
Comment was it a fair analogy for an acute emergent situation versus sort of a more chronic situation?
I think that if you have somebody who's housebound and we have no test that's reliable, to look at because I'm not saying that we don't look at the test, we do look at the test, but say the test shows that they're in the lowest 3% of the population for thyroid, for the free T4, and they're tired, achy, weight gain, cold intolerant, and exhausted, post-child clinically. Would you say not to treat them because they're not in the lowest 2.5%, but they're in the lowest 3%? Or would you say that, okay, looking at doing an assessment of the risk benefit and probability assessment, that if they have these symptoms and they're in the lowest 3% of the population, despite the test being normal, then maybe a therapeutic trial is warranted. There's no right or wrong in this. It's just there's different approaches.
Okay. Can I tell a little story then? I know it's getting late and you probably want to leave, but let me tell a little story. So in 2007, I found myself in the Suba District Hospital in Western Kenya, which was 160 kilometers west of Nairobi to Lake Victoria. Find the electric line and take it south for another 160 kilometers. And there was a cinder block building with a tin roof, and that was the Suba District Hospital. And I went there to visit a friend, and I ended up staying there for 9 months. When I got there, the Coulter counter, which was the blood counting machine, was broken, and they told me the technician would be around in 3 months to fix it. When I left 9 months later, they told me the Coulter counter was broken, and the technician would be around in 3 months to fix it. They had an X-ray machine. It was a cobalt machine that was unshielded. I wouldn't let them turn it on. So I always remember this one patient. So the average age lifespan for a male there was 46 at the time, and a female 52. That was the average age lifespan. There was a patient there. He was about 50 years old, and he had heart failure. And the intern says to me, he says, well, we give him diuretic for 3 days and he gets better. And then, when we stop it, he fills up again. And I said, well, why are you stopping it? And he says, well, he gets neuropathy. I said, well, you need to give him potassium. And he says, we don't have potassium. They had every AIDS drug there, but they didn't have potassium. So having dutifully been graduated from the UCLA School of Medicine's acupuncture program, I had learned pulse and tongue diagnosis. And let me tell you, there you needed to know how to do that. So I thought, so not an hour later, it's middle-aged there. She was 20 years old, came in respiratory distress. Do you have an ambu bag? No. Do you have, oxygen? No, they didn't, nothing. So I didn't, I said, well, what do you do here? She says, well, they usually die. And so they had sterile hypodermic needles. So I just opened a bunch of them and I did a lung treatment, acupuncture lung treatment. And it was a long 5 minutes before she went from gasping for air to her breathing sort of stabilized. And about 10 minutes after that, she woke up, looked around, saw she had a bunch of needles in her in the B27, if you know, and all over. She kind of pulled them out and said, what's going on here? And got off the table and left. So just a little story. So what we did actually with the heart failure guy was the forest there had foxglove in it. It was native there. They didn't, like I said, they didn't have digitalis, they didn't have beta blockers, they didn't have diuretics, but they had an internet connection, even in 2007. So I found out what was in the forest, and I got one of the medicine men to come, and he came in full regalia, and he went out into the forest and he found me foxglove, and we chopped it up, and then we didn't have capsules or anything. So what do you do with it? So we just put it in some water and have him drink it. How about nebulizing it? Well, if you have a nebulizer, yeah, that might work, but we didn't have that either. So the question here is for Dr. Quinto, how about nebulizing bioactive silver hydrosol to oxygenate the lungs. Well, again, if we didn't have those kinds of things.
Mhm.
So, you know, in where I was at the time in Wilkes-Barre, Pennsylvania, we did have them, but in the Suba District Hospital, we didn't. So, so you kind of learn to live by your wits. So, so whoever, you know, so the like Dr. Teitelbaum, I agree with you. You know, there isn't any right or wrong. You sort of have to follow your, you know, your instincts. But I think some of it might be, experience. You know, things that I think back now. You know, when what I knew about thyroid disease 30 years ago was that I looked at the thyroid, looked at the TSH, and if it was flagged high or low, I sent them to the endocrinologist and told the patients they were going to get a skinny needle biopsy. That was about it.
Yeah, the times there are changing.
And we couldn't figure out when if the TSH was 0.04 and we gave them more Synthroid, that it actually went down instead of going up. We didn't, you know, so I think some of it might be experience. I don't know, you know, Dr. Teitelbaum, you're the, you know, the expert here.
Well, we're all experts here. I wanted to add one other thing too, because we talked about the sinus and the Candida and the infections, and I didn't talk as much as I should about the importance of the silver. If I'm going to use the nose sprays, I will use these Argentin 23 or the natural immunogenics silver nose spray, because I use the two together. We can't put silver in the other things because they'll precipitate out. So those are separate, but those really can have a very strong benefit for people. And Seth, one of my favorites is the cream, the aloe skin thing. If you have people who have itches that just don't seem to respond to anything, you'll be surprised, you know, put that stuff on. But I am picky about what I use for silver, because you know, I'm having 11 grandkids and 5 kids. I like Smurfs and blue people, but I don't want them turning Smurfy with argyria, taking silver that is going to build up on their skin. And with the natural immunogenics, there's no risk of that. They do it properly. The silver is a very important thing to do. And William, again, to me, the art of medicine, we have been trained against trusting our own art of medicine and instincts. And I think that's a horrific thing. We've been trained that tell a person stay home. I don't even want to talk to you. Just do the tests. And I'm sorry, the tests are a tool, but the art of medicine to me is an incredibly powerful tool. And we're losing that because people don't trust their own instincts. And that's a big problem, because otherwise all we end up doing is being shills for the pharmaceutical industry.
Mm-hmm. Dr. Patel, you have anything? Dr. Patel, you have anything to add? This is kind of your bailiwick too. Dr. Patel will be speaking at our conference also.
Thank you. It's a wonderful, very nice lecture. And I just have a question about those with the cardiac problem, with the low ejection fraction, and patient being on every nutrient you mentioned there, and still the ejection fraction is 20. So where would you go after that?
After that, there's a nice Russian study. Maybe I shouldn't have said that it was Russian, but the study was still what it was. It was actually placebo-controlled in people with very, very severe refractory heart failure. And they found that giving the magnesium aspartate, it was not just the magnesium, but predominantly the aspartate was contributing to the energy thing. I think it was 3,000 milligrams twice a day, which is not a lot of magnesium. It sounds like it, but it's mostly the weight of that is the aspartate molecule. Using the Hawthorne. These are the next two things that I would go with. But if you look up, get the Cures A to Z phone app, and then look up heart disease. This is all listed out, including the next steps after the initial 5 that I gave.
Thank you.
Welcome.
I've had that for about 5 years, and I'll highly recommend it. I know that's I think that's yours also, right?
Yeah, it's $200. No, I'm teasing. It's free. There's a $2 upgrade.
No. Yeah, I know. No, I actually spent the $2 a number of years.
Oh, well, there you go.
So But it's a very good app, and it has, if you're stuck, if I'm stuck, I have it by my desk side here. If I get stuck, I can always find something to do. There's always something else that we can add in. CURES, and it's really pretty good. It's a really nice app. It's very complete, and I use it all the time. So, not that I'm the arbiter of anything. So, benefit from Argentine 23 nasal spray decreases the viral cases and recovery is fast.
I think the Argentine 23 or the natural immunogenics silver nasal spray is brilliant. I recommend them routinely for anybody, but I use it with the prescription one and the diflucan. But even just using the silver by itself, silver is a wonderful molecule.
So have you heard anybody developing problem from silver? The other day I received a call and I'm going to see that patient, but the ionic silver was used in her nose, and they also gave her by mouth, and she is severely debilitated, severe chemical sensitivity, and abdominal pain.
I've never seen that from silver. I would wonder if she killed off something and was getting a Herxheimer reaction. The main problem with the silver is if you get too much, they get argyria, they turn blue. They don't feel anything. They just, as I mentioned, look kind of smurfy and it doesn't go away. So I've never seen that kind of a reaction from silver. Seth could probably answer that better than I could. But in 45 years, I've never seen that. But it would leave me, if it even had to do with the silver, the question is, what were they treating using the silver? What they were treating is more likely component, or the silver killed something. Those would be my first two suspicions. Seth, do you have thoughts with that? Oh, you're on mute. You're on mute, Seth. You have to unmute yourself. Or William has to unmute Seth.
I think he can do it himself.
Okay.
There we go. Sorry, guys. Please forgive. I was trying to respond by text. Yeah, certainly, depending on the silver, the species of the silver is going to dictate how powerful it is or not. So in the case of a bioactive silver hydrosol, a sovereign silver, and Argentine 23, die-off certainly can happen. I remember my ex-wife being treated for Lyme and had a complete meltdown halfway through her treatment from the die-off. So unless you've got a lot of liver support, remember, no matter what, silver is leaving through glutathione-dependent phase 2 liver detoxification. Girls, go please. Glutathione-dependent phase 2 liver detoxification is the pathway for excretion, so it's going to tax the glutathione stores in the body. Preloading with glutathione will preclude that. Milk thistle is another good thing, an organic diet, of course. And then you can back off the treatment as needed until the patient does recover from a Herx, but a Herx isn't the end of the world. It's obviously a sign that things are happening. Helping the patient through it is as important as what you're doing to help them recover from it.
Okay.
Thank you for that. Thank you for a magnificent presentation.
So thank you. Dr. Quinto, I gave you my contact information. Well, everybody has it. If you'd like to present some of your information for us, please get in contact with me or leave me your contact, because I have endless Tuesdays to fill up.
I can't wait. For the record, I'm not Dr. Quinto. I'm Seth Quinto. I'm Stephen Quinto's son. I'm sales manager for the professional side of our company, which is Argentine 23, of course, but I didn't come
everybody's a doctor here, no matter, even Dr.
Oh,
Burgess.
I love you guys. You know what? We all honor the oath. We honor the oath. I love you guys. And gals.
So
honored to be here.
I have endless Tuesdays to fill up. Doesn't have to be a doctor. So we've had yoga instructors, we've had suicide hotline persons. They've even had me, every once in a while.
I'd love to bring, I think, I can do a lot here. Hold on a second. Am I on here?
Okay, terrific. I gave you my contact information. So if you send me yours,
I will definitely follow up.
I'll make sure it happens. Dr. Teitelbaum, I know it's going on for a while here. If anybody else have any questions, comments, Dr. Teitelbaum will be on 1:30 Sunday afternoon. My only regret is he's not with us live. My second regret is that we didn't go to Hawaii to be with him live. And the way the way things have worked out with the hotel in Las Vegas, I might just blow the whole place up because they just drive me out of my mind. So Dr. Patel, you're on. When are you on? You're on.
I'm on Saturday.
You're Saturday at
At
2:30. So Dr.
At
Patel's on Saturday at 2:30. Dr. Teitelbaum's 1:30. Dr. Burgess is on Sunday at you have you at 4:45. We are up, by the way, we're up to 26 AMA AOA category 1 credits now, from 24. We have a really packed a lineup on it's going to be a long 3 days. We have a reception Friday night after the last lecture, and Saturday night Dr. McCullough will be speaking. He's our last speaker, and then there's a reception with him out on the terrace there. It's at the Flamingo Hotel. I know some of you have had issues with the hotel, as we have. If you have, let me know. If they've given you, because they kind of bait and switched us with prices. So they told people that it was sold out, and then they told us we didn't sell enough rooms. So it's been a bit of an issue. Mr. Dr. Quinto, I'll get in touch with you. Thank you for your information. We will firm that up. And anybody have any comments, questions? Dr. Teitelbaum, we can't thank you enough. It was really terrific to have you with us. It's an honor, and it's going to be an honor next week. Here's another, let's see, great lineup. Yes, we know that. Sean Devlin, DO, will be speaking on his revolutionary use of ozone and silver for Lyme disease at the AAOT.US, American Academy of Ozone Therapy, June 2nd to 4th in Denver. So there's that. Okay. And next week, Dr. Halassa will be back for round 2 on his immuno oncology series. Then after that, we have a really great lady that I gave a talk to with functional microcurrent, specific microcurrent, and she's got really fascinating, tale to tell, and she's done some really terrific work with sports figures and whatnot. So we'll have her on. And anybody else who has anything to present, please let us know. Like I said, there's Endless Tuesdays. We're here every Tuesday at this same time, same station, 8 o'clock Eastern, 5 o'clock Pacific, and 2 o'clock in Hawaii, right, Dr. Teitelbaum?
3:51 right now. I guess 2 o'clock.
Okay. So I always ask our speaker, we like to record this, and we have on our website, we put the recordings so anybody can look at them. And we have, we've been doing this for more than a year and a half now, and we have quite a, a library now. So it's aosrd.org/webinars. Let's see, I gotta get for everybody. There we go. That's where the webinars are. I usually have them up within 24 to 48 hours. Sometimes we get a transcript with it. For the, again, aosrd.org/event will take you to the website for the conference. And there's some discounts there for almost everybody. And if they're not at this point, let me know and we'll get you some sort of discount. Even you, Dr. Burgess. So
Thank you.
okay. So thank you, everybody. Again, any last comments, questions? Thank you so much for being with us. Thank you for supporting us. We'll see you again next week. Thank you, Dr. Teitelbaum. It's been a pleasure.
Welcome. Be well, everybody. Aloha.
Put a good word in for Dr. Hertog, so maybe we can get him too. Okay.
Mahalo. Mahalo.
Aloha. Be well, everybody.
God bless everyone. God bless everyone.
Okay.